Thanks for joining us today. We have Dr. Trevor Turner, and he is a non-surgical orthopedic specialist. Can you tell us about how you got into orthopedics in general, like you were a kid and what happened?
So when I was in medical school, initially I was really fascinated by trauma, and I spent some time doing trauma surgery. I did an internship in surgery at UC San Francisco, and I had a question at the same time of what was happening to these patients after they were discharged. So we would see people, we would stabilize them, we treat them in the ICU, and then a lot of times I never saw or heard from them again. And for me, I'm sort of a long-term relationship, people-driven kind of a person. So I wanted to be able to go into a specialty where we took care of people with big problems, and a lot of times those translated into either neurologic issues or orthopedic issues or musculoskeletal issues. But then also to be able to create that long-term relationship with them and then focus on things that really matter to them. And most of the time when I ask people, what do you care about the most? Oftentimes it has to do with function. So I am a physiatrist or a PM&R physician, which a lot of people don't know what that means, but basically we're experts in sort of non-surgical orthopedic care. So we do everything from, the neck all the way down to the toes. And my job is basically do a combination of things. So I see patients and evaluate them and primarily try and treat them with either exercise or rehabilitation plans as well as medication. And then we have a variety of non-invasive type of procedures under ultrasound guidance or x-ray that we offer them to basically help them return to function as quickly as possible and ideally at the lowest risk. So PM&R covers a pretty broad range. So people out of PM&R go into treating brain injury, spinal cord injury, strokes. They do even some people doing hospice care, some people that strictly work an inpatient in the hospital, and then some people do sports medicine and pain medicine. So kind of the practice as it's evolved here where I work is sort of almost a hybrid between sports and pain medicine. But when somebody comes in and says, hey, I have a knee problem and I can't pick up my grandchild, and the most important thing for me is to be able to pick up my grandchild every day. That seemed very human and very relevant to me. And so that's how I actually discovered PM&R or non-surgical orthopedics.
Can you tell me what makes you specifically different than other PM&R specialists?
When I was finishing medical school, I took an ethics class, and we had an ethics professor who by the end of the course said to everyone sitting in the room, he said, if you would recommend medicine as a career for your family member or your friend or for somebody who's really interested, would you do it? And at the end of that class, I was the only person that raised my hand. And so that I kind of felt like there was a crisis in healthcare, because realistically, like, these people I was graduating with are going to be physicians. And, if they were going to be helping care for my parents or helping care for my siblings or whomever, or me, we need physicians who are mission driven, that are very inspired and feeling, joyful about their job. And patients can tell, they can tell really when you go to somebody who you're able to connect to and who has kind of that vulnerability and that emotional connection. And it makes people better. And I think when patients go to somebody who's burned out and exasperated and not connected, they don't do as well. There's a huge spectrum of people I have to interact with well and to communicate with very effectively to be good at what I do and to optimize a patient's outcome. And so that's kind of what's unique about the non-surgical orthopedics. I guess the other thing I would say is that, we see sort of this huge national epidemic with the opiate crisis. And so, that crisis is going to continue to be a problem until we can go to patients and we can say, look, I have a huge armamentarium of things that is going to help you recover your function and to help you do it with less pain. Basically when patients come to us, we have a range of things we can offer, right? So at visit one, we learn all about where their functional deficits are, and then we talk to them about what their goals are. And then it becomes a discussion of, okay, we can use physical therapy and different exercise. We can use bracing. We can use medications, which usually consists of many different classes of medicine. We can use procedures, which now we have more procedures than ever based on the use of the ultrasound probe as well as the x-ray or the fluoroscope device. And I would say my practice personally is leaning more and more with ultrasound because of how dynamic a tool it is. And so we improve the way we diagnose people. And then lastly, of course, there's surgical options. And so, we have a lot of people who are looking for options other than just taking a pill. And so my job is to basically make those viable for them.
Okay.
Um,
So you mentioned that if you get a patient that's like, I want to pick up my grandchild and help
mhm,
me to, fix this problem that's keeping me from picking up my grandchild. Now,
sure.
since your sports medicine practice, I mean, do you also work with like professional athletes who are like, I want to optimize my physical body. Maybe I'm not injured, but I want my physical body to perform, the best that it can.
Yeah, absolutely. Yeah. And so, and a lot of that has to do with our founder, Dr. James Andrews, who, has a lot of people that pick up the cell phone and call him and come here for second opinions or definitive
Okay.
treatment, et cetera. So, we do offer kind of procedures for what we call regenerative medicine. And that has
Okay.
come
Yeah.
to mean a lot of things depending on who you talk to. For us, we only use regenerative medicine or cell based therapy strictly for orthopedic and musculoskeletal applications. And usually that involves one of two things. So it's either taking blood from a patient's vein and spinning that down in a centrifuge to isolate a concentrated amount of growth factors that come from your platelets. So that's called platelet rich plasma. It's abbreviated PRP. We use it in tendons, ligaments, joints, and
Hmm.
then, and also now we use stem cell as well. So stem cells we aspirate from the hip. There's
Okay.
lots of people trying to use stem cells from other sources, but really, kind of the only evidence that we have that's really strong, as well as what's approved in the United States by the FDA outside of a clinical trial, is to take it from the bone marrow. And so we use that
Okay.
similarly for treatment of different joint problems as well as tendons and ligaments. And so now we have more and more people who are kind of coming and saying, look, I've read about some stuff on the internet. Can you tell me about, separate the fact and the fiction for me, and what things do we really have evidence for and what do we don't? Because if this is going to be considered investigational by the FDA, we have to be able to give people very sort of comprehensive opinions on something that is an emerging clinical field that doesn't have resolute data for every single application. But I think when people think about optimizing performance, they're looking for things that are not just sort of the old standards of treatment, and they're looking for things in which they can actually focus on long-term improvement of outcomes or regeneration of kind of their own tissue by using their own body's material.
Okay. That's very cool. So you're basically like a doctor that optimizes the human body and the human experience.
That's definitely our goal. Yeah. And it depends, everybody has a different goal. And so that's part of my job is that when you come in the door, one, we have to give you a good assessment and diagnose what the problem really is, because sometimes that hasn't been done correctly in the past. And then to give somebody a range of options and to really be a partner in their recovery. So I think, we have this idea that, years ago, the physician was this old gray-haired gentleman with a black bag who comes to your house and says, this is what you must do to get better. And I think now that healthcare has evolved, it's much more that, look, I know that you're going to look up stuff on Google. I know that you're going to research things before you come in. And when you come into my office, my job is to give you, say, look, this is really what the good data says, and this is some of the stuff we found that maybe is questionable. But let's figure out a way together that's consistent with your goals to help you achieve the goals that you want.
I love that. So what's your favorite part about what you do?
I mean, the favorite part is always just when somebody gets better, and you have that kind of light bulb moment come on. Especially, it can be really, really challenging if you've seen a patient who's had a bad experience in the healthcare system, and unfortunately, those experiences abound because we have a very fractured system, and or maybe somebody saw a provider they weren't connected with, or there's a myriad of reasons, or maybe it was too expensive, or they couldn't get access. So there's a lot of reasons, but I think when you see and you feel that restoration of function, and that patient comes back and has this smile, they have this joy, this resilience on their face, that they said, what, I never thought I would do this again. Like I thought I would never do this again, and then they come back and say, I'm finally doing it, and they find meaning.
What's your least favorite part? What's the hardest part?
Is things that basically kind of disrupt us from the clinical encounter, right? So what do physicians really want to do? Well, so we train to be able to go in that room and to encounter someone when they're most vulnerable and to figure out what's wrong, build a relationship of trust, and then treat and heal them, right? That's what we want to do all day. outside of that, we have a lot of things that sometimes are getting in the way, right? So we have sometimes it's an insurance company that won't approve a treatment that we know to be the right thing. Sometimes it's a medication that's just too expensive. Sometimes it's somebody who's supposed to be helping you, on the executive team who's saying, no, we need to use a different process. And you're saying, no, we need this process because we have to enhance the human part of medicine. Sometimes it's clicking on a screen and typing in an EMR. And all you want to do is be making eye contact with that person and examining them. But instead, you're spending your time typing notes, right? And anything that's taken away from that, I think we feel deprived. And I think that's why you start to see studies about rates of burnout, because, I think some physicians who expected that once they got through residency, it was all going to be about just treatment of the patient. Once they get sort of constrained by the system, they find that a lot of it is not. And that's the part that's hard.
I feel like that's very common in so many different industries, where there's a sort of business element that takes so much energy and focus and attention, and then the customer or the patient receives that and they feel neglected because of that. And it's not necessarily that you want to pull yourself away from them, but it's part of the whole functioning of the business. So what would you say is the biggest challenge in healthcare? Typically there are 4 challenges, and it's either like the money or the time or the people involved or the people you're working with or the patients or your passion. And so money, time, people, and passion. What would you say is the biggest struggle right now?
Time. Yeah, I would say time. Yeah, because there's an ocean of need. And like we have a commitment here, for example, where if somebody calls into Andrews Institute and they say, look, I'm having a shoulder problem and I need to be seen, because I'm in pain, that we signed a charter that basically says no matter what's going on, we are going to figure out how to see that person within 48 hours, which is pretty demanding. When you have, a really successful full clinic and you're seeing sometimes 30, 40, 50 people a day, right? Mm-hmm. And so the challenge becomes is, look, I wish I could go into the room and spend an hour with everybody. I would love that. I mean, it would be tremendously satisfying for me. The patients would love it too. And I think the question is we have these constraints and we have time constraints. So how do I make room for everybody that needs help, but also be present in the moment with you in such a way that you feel like I'm not rushing through my day, that I'm on time, that I'm sitting down with you, we're making a connection, we're emotionally, connected, we're making a plan together. That's something that you have input into. It isn't just lightning visit, this is what we're going to do. So I think that's the hardest part.
So how would you describe yourself as a person, the person that went into medicine, the person that's in that room, that's present, when you're your best version of yourself, and the whole back of like why you did this? How would you describe that person?
So I've had problems with my own like disc herniation and radiculopathy, which some people call sciatica. I'm a dad, so I've been through labor with my wife and then seen what happens after your baby gets born and what the next few days are like. And that was incredibly terrifying. It was also obviously very joyful, but it humbles you. I've been through a situation where my dad was diagnosed with a brain tumor. And so all of the family and emotional fallout that goes from that. Mm-hmm. So I think, you never want people to suffer. You never want people to have to go through things that are going to impact them in a negative way. But I think the key is finding the perspective and the takeaway from those moments. So when you've been in a setting in which you have shared in that vulnerability, when you can offer that, when you come in the room to connect with somebody, I think that's tangible, and it becomes something that probably enables you to care better. Healthcare was always kind of like a vocation, I think. It always kind of felt like a calling, which is a little bit different from somebody who's just going to a job. And so I think in that context, having the sort of that overarching sort of mission as to why you're there, kind of gives you resilience. It gives you the joy to make it through the lows.
Well, thank you for doing this interview with me. And I appreciate it.
All right. Hey, thank you so much for your time.